All right, moving along, we're going to hear from our genetic counselors tonight. I would like to welcome Shabnam Asghari, who is a certified genetic counselor here at Perlmutter Cancer Center, and Elizabeth Mandersky, who is also a certified genetic counselor here at the Cancer Center. Come on up.
Hi, so I guess we'll be closing up, but we're going to be talking about genetic counseling as it relates to hereditary cancer susceptibility in the context of gynecologic cancers. Okay, so we're going to start by going through, what is genetic counseling and what does a genetic counseling session entail. We'll talk about what we consider sporadic versus hereditary types of cancers. We'll go through two of the more common hereditary predisposition or cancer predisposition syndromes that we think of when we think of gynecologic cancers, BRCA-related cancers and Lynch syndrome. We'll discuss genetic testing, the benefits, risks, and limitations, what kind of information you can get from doing genetic testing, and we'll touch on some other considerations as well, like different types of reproductive options we might discuss with our patients, as well as any support services that we might offer in a session. Okay, so genetic counseling, as put forth by the National Society of Genetic Counselors, is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And more specifically, cancer genetic counseling, our goal is to identify those individuals and families who are at an increased risk of cancer, with the goal of promoting awareness, early detection, and cancer prevention. Okay, so the purpose of genetic counseling, when someone comes into our office, we do three general things. First, we use the personal medical history as well as the family history to assess the chance of a disease or a cancer, and we interpret a personalized risk assessment from that information. We also provide education to our clients regarding inheritance pattern, different types of testing that's available, as well as management options, prevention, other resources, or clinical trials that may be right for them. And of course, we provide counseling. It's in the name of what we do. We promote informed choices and help people to adapt to any risk they may face or a diagnosis that they may face. And also, we establish risks for family members and offer the appropriate cascade testing if needed. Okay, so these are some examples of some people who we might see in our office. So individuals who have a personal history of cancer, individuals who have known mutations running through their family and they want to see if they carry the same mutation or not. People who might use this information to change things about their healthcare management or their treatment for certain cancers. We might see people who have never been affected by cancer if they have a suspicious or significant family history of cancer and maybe that family member is not available to get testing themselves. But it's also important to note that not everybody has an indication for genetic testing. Not all personal and family histories of cancer are suspicious for a genetic cause. So in the first genetic counseling session that we do, we call it the pre-test session. This is where we go over really to hear from the people that we're meeting with what is the reason for their appointment, of the categories that I just went through, what's their indication for the testing. We use their medical and family history to create a personalized risk assessment, or in other words, what is the chance that the cancer in the family is hereditary. And using either the personal and family history alone or in combination with genetic testing results, we might give a risk assessment for that patient. We also a lot of times use NCCN, or the National Comprehensive Cancer Network, as well as the American Cancer Society guidelines and some risk models in order to determine that information and provide patients with the most accurate risk that we can in that sense. We'd also talk about different types of testing options, the insurance coverage for that, some risks, benefits, and limitations, the different types of test results we can get back, so sometimes it's not always as black and white as we think it's going to be, as well as implications for themselves and for their family members, so what might this mean for them and their families. Also, some potential psychological consequences. We might go through the what ifs. And we talk about a specific law called GINA, which stands for the Genetic Information Non-Discrimination Act. And that's important because it does protect you against information being discriminated against based on genetic information in some places and not in others, such as it protects you in your workplace and through health insurance, but you're not protected from discrimination from your life insurance company or any long-term care and disability. Okay. And so I do apologize. For some reason, the slides are kind of on a timer, so they keep switching back and forth, so I'll do my best to control what slide we're on. Some of the benefits of genetic counseling is that, it might provide some explanation for the personal or the family history of cancer. For some people, they might change their treatment plan. So some people, if they know that they have a risk for a second type of cancer, they might choose a different surgical option in their treatment. They also might have availability of specific different types of treatment, like we spoke about PARP inhibitors before, or other types of clinical trials that might be of benefit for people with specific genetic mutations. And additionally, they might choose to undergo risk-reducing surgeries or preventative surgeries, such as oophorectomy or removal of the ovaries. And so other than treatment options, some people might choose to change management recommendations in order to increase early detection or try to reduce their chances or prevent cancers altogether. And that might include increased surveillance, different types of chemo prevention, and that sort of thing. There it goes again. So more or less what we're doing is trying to identify high-risk individuals and their families, with the goal, if they have cancer, being aware of these different options that they might have or a risk for a second primary cancer, or if they don't have cancer yet, the goal being to increase early detection or prevention, and really to be proactive in taking control of your own health care. Okay, and so this kind of just goes through a similar theme, different types of risk management recommendations that one might get going through genetic counseling might be changes to surveillance or risk reducing strategies, as well as different types of treatment decisions that might be made available. So now we'll talk about the differences between sporadic and hereditary cancer. Most cancer that we see is actually considered sporadic cancer, which we normally think of as related to age or environmental factors or lifestyle factors or a combination thereof. Only about 5 to 10% of all cancer is considered to be hereditary, and what that means is that we can actually find a specific genetic mutation that's thought to be the cause of that cancer. The rest of that pie, the familial risk, makes up the portion where, we see cancers in families and it seems suspicious, but we're not able to pinpoint an exact genetic cause. Okay, so when we're talking about hereditary cancer, we expect to see a few things, or we look for a few things, and one of them being an early onset cancer. And early onset in cancer terms is usually less than 50 years of age. We also look for similar or related cancers in multiple people and multiple generations. We also look to see if any one individual was diagnosed with more than one cancer or bilateral cancers in organs where that applies. In addition, we look for rare cancers, like we've been talking about. Ovarian cancer is a rare cancer. And also certain ethnic groups we know have a higher rate of specific genetic mutations. For instance, the Ashkenazi Jewish population is found to have higher incidence of mutations in the BRCA1 and 2 genes, which we'll get into a little bit more later. So most hereditary cancer predisposition is inherited through what we call an autosomal dominant inheritance pattern. And what that means is that you only need one copy of the mutated gene in order to have this risk for cancer. And we know we get half of our information, our genetic information, from our mom and half of our genetic information from our dad. And so that means all of first-degree relatives would have a 50% chance to have the same genetic mutation. So in other words, 50-50 chance to pass on to any children, 50-50 chance that any siblings might have this genetic mutation too, and 50-50 coming from the parents. When we're talking about hereditary ovarian cancer, approximately 25% of all ovarian cancer is caused by a mutation in cancer predisposition genes. So the majority of these are in BRCA1 and 2, which Shebnem will get into a little bit further. There are other known genes that have implications in ovarian cancer, and a large majority of the causes, hereditary causes, remain unknown. And in terms of hereditary endometrial or uterus cancer, approximately 5% of this cancer is hereditary, and most of this is due to mutations in what we call mismatch repair genes. And you can see these 5 genes listed after that, and those are associated with hereditary predisposition syndrome called Lynch syndrome, which Shebnem will also dive into a little bit more deeply. But just looking at this graph on the horizontal axis on the bottom, we're comparing somebody all the way on the left who has the average general population risk for ovarian cancer and uterine cancer. And we're looking at a couple different types of genes or predisposition syndromes and their risks for ovarian and uterine cancer. So you can see that these genes have an increased risk compared to somebody in the general population, and that they might have risks for both of these cancers or only one or the other. You might want to start over.
Okay, so I'm going to take a deeper dive into BRCA1 related hereditary breast and ovarian cancer syndrome, which is related to the BRCA1 and BRCA2 genes. You might hear it commonly referred to as HBOC, as just a short form. And I apologize, I'll try to do this without coughing. So HBOC is a pretty well-described cancer syndrome. We have a lot of data, a lot of research. We've been testing the genes BRCA1 and BRCA2 for over 20 plus years. But we still don't know a lot. So we still can't specifically guess or assume what kind of cancer someone will get. So we do have to discuss all of the potential risks that an individual may have, and that can be different based on if someone is female, male. So the breast cancer risk, if we use old data, we know it's up to 80% for a woman in her lifetime to develop breast cancer. Recent literature suggests that it's a bit lower than that, but it's still significant. And for males, the risk is about 7%. When we compare that to the general population risk of less than 1%, it is elevated, and the data is more strongly leaning towards BRCA2 with that risk. Ovarian cancer has a risk of about 50%, but the new data kind of has it around 40 to 50, so it is, again, kind of a moving target. And BRCA2 has a lower risk, but still significant over the general population risk. So like Dr. Levine mentioned, ovarian cancer being a rare cancer and having such a contributing factor with BRCA genes, everyone is recommended to undergo genetic testing or the consideration of it with that diagnosis or a family history. The fallopian tube, as well as the peritoneal cancer, is also kind of lumped within that category. The other cancers that we also know that fall within this spectrum is melanoma, pancreatic cancer, and prostate cancer. Pancreatic cancer and prostate cancer have gotten a lot more attention recently and have been linked more strongly with BRCA. So now the guidelines have shifted to also recommend genetic testing for anyone with a family history of pancreatic cancer, as well as metastatic prostate cancer or early onset prostate cancer with additional family history. And this is something that's fairly new, as about a month, and there's a lot of data suggesting that link. The management recommendations have, for the most part, stayed the same. There has been some new shifts as far as what we recommend with regards to the risk-reducing procedure related to the ovarian cancer. But I'm going to first start talking about what women start to do related to breast, because that's when the earliest screening happens. So self-breast exams, we encourage all women to start around age 18, and at 25, clinical breast exams can be added and happen every 6 months to 12 months. Annual breast MRIs do begin around 25 to 29 or based on family history. And that's just due to issues with density and other factors. And then we add in the mammogram at age 30 to 75. And some practitioners will alternate the MRI and the mammogram every 6 months. Others will have them happen at the same time. There's really no consensus on that. At NYU, most of the physicians tend to do a biannually so staggering the two every 6 months, but having each one happen every year. There's also the option of a risk-reducing bilateral mastectomy. And this is a very personalized decision. The survival benefit doesn't change from women who screen for breast cancer and for women who decide to have a mastectomy to prevent or reduce the chance of breast cancer. So it is a personalized decision, and it really just depends from where we're sitting, where we're meeting a woman, and where she's at in her life. As far as ovarian cancer, like Dr. Levine alluded to, there's not great screening. Obviously, the transvaginal ultrasound and CA-125 can be an added benefit or option, but really the real guidelines or recommendations kind of suggest that a woman should consider a risk-reducing bilateral salpingo-oophorectomy, which is removal of both ovaries and fallopian tubes. And for BRCA1 being such a high risk, it's usually earlier, so about 35 to age 40. We do want to keep in mind childbearing options, but again, we also have, it depends where we're seeing people and working with their reproductive choices while also discussing those risks. For BRCA2 carriers, given that this is a lower risk, we can delay it a bit to about 40 to 45, and again, considering childbearing options. And of course, at NYU, we have the opportunity to also offer women the bilateral salpingectomy followed by completion surgery later on. And there are chemopreventative options like oral contraceptive pills until the point of surgery and tamoxifen from a breast cancer risk reduction option. But these again have to come with discussion with physicians because they have their own risks and limitations. For men who are BRCA2 carriers, we do recommend self-breast exams just to have more awareness around their chest area, specifically around the nipples, and also clinical breast exams every year. There's no real recommendation for mammogram. However, if a male does have gynecomastia or more breast tissue, there could be consideration of mammogram, and again, that's at physician discretion. At age 45, we do recommend prostate screening for BRCA2 carriers, and that can be considered for men who are BRCA1 carriers, but it's not widely recommended. And for men and women, we do encourage seeking information about melanoma, screening, like annual dermatologic exams, and of course pancreatic screening is limited. However, we do have a pancreatic clinic at NYU, so we do refer all of our patients who are BRCA positive so that they can establish care and either screen or participate in clinical trials when appropriate. So I'm going to move on to Lynch syndrome. So Lynch syndrome is as common as HBOC. We just don't get a lot of information about this. There's not a lot of media around BRCA or about Lynch, and not a lot of celebrity around it, but it is as common and has 2 gynecologic cancer risks associated with it, unlike BRCA. So it is an important one to keep in mind. Previously, it was known as hereditary non-polyposis colorectal cancer syndrome. The name did change as it reflects the physician who identified the syndrome, but also to take away that label of that it's just a colorectal syndrome. The penetrance is quite high, and there are 5 genes related to the cancer or to the syndrome, and we do offer screening at NYU on tissue so that we can elect to identify people who could potentially have Lynch syndrome. We can discern if it's more likely to be sporadic or genetic, and those are listed as MSI and IHC. It accounts for 2 to 3% of all colorectal cancer, 2 to 5% of endometrial cancer. It is early but variable, and as far as ages, there are some variations to that based on each gene. So we do spend quite a bit of time talking with patients based on gene-specific risks, since there are 5 related to Lynch syndrome, and most of the colorectal cancers tend to be right-sided. I'll skip over this for time, but what I want to highlight here is that for women specifically, the risks are different, and the risk for colorectal cancer and endometrial cancer can be equal or the same. And for women who have Lynch syndrome, endometrial cancer may be their primary and only cancer, so we can't overlook that. So when there is a family history or a personal history or results on tumor that kind of highlight that there might be a suspicion for Lynch, it is important to make that referral, even though a woman may not have had colorectal cancer as well. And again, the ovarian cancer risk also exists. There is screening, so endometrial biopsies can happen. It hasn't really been shown to be beneficial. So again, it boils down to having a dialogue with a gynecologic oncologist and managing physicians to determine when is best to potentially undergo a hysterectomy, as well as the risk-reducing option of removing the ovaries and fallopian tubes. Colonoscopies do start fairly young, much younger than any really other syndrome outside of FAP, but we do start them around 20 to 25, which is about, significantly younger if we're comparing that to the general population, and they do happen every 1 to 2 years for the remainder of that individual's life. So genetic testing, this just highlights what we're doing now. We're doing panels. We see that there's an overlap between a lot of genes and the types of cancers that they cause. So this kind of adds a benefit that we can get the results that we need quicker. We can also look for things that we may not be thinking. So even though I might be suspicious for BRCA, I might get a Lynch result in someone who has ovarian cancer. So this gives us the opportunity to get those results faster and give patients an answer that they can then use and their physicians can use. These are just 3 additional genes that have been added to guidelines that do come with recommendations for surgical intervention. BRIP1, RAD51C, and RAD51D, they all 3 have ovarian cancer risks and do come with recommendations for removal of the ovaries. They do have their own independent options and ages, and so that that's working with physicians to determine when it's best, and it is individualized. Reproductive options, this is in no particular order, and every person will come at this differently, but natural conception with no future testing, prenatal diagnosis, we can do PGD, which is pre-implantation genetic diagnosis, looking at embryos prior to transfer to afford couples the opportunity to not have a pregnancy affected with the genetic mutation. Fertility preservation in patients who are going to undergo chemotherapy or who have genetic mutations and are considering these surgeries but aren't ready to have children. So egg freezing, embryo freezing, there's the option of donors as well as adoption, and surrogacy, which is not on there, I apologize. Some supportive services are listed here, and I believe you have handouts of our slides, so I won't spend too much time on this, and there's many more that go far exceed this, but these are some of the highlights and the way to find a genetic counselor, and we have cards if anyone needs them at the end. So the family history, in summary, is quite important, but it is a limiting factor. Sometimes family histories won't match. So there are other aspects to what we do to kind of navigate when we should test and who we should test. There are specific criteria that we do follow, and we do know that outside of BRCA and Lynch, though they are the most common, there are things that we can identify, and we do identify that do have implications not only for the individual and their management, but also for their family members. And that highlights what Dr. Levine was mentioning about cascade testing. Cascade testing is getting our family members who are unaffected in so that we can prevent the cancer when possible in those relatives. And genetic testing can impact clinical management, like I mentioned, and the psychosocial aspects are quite heavy. And as genetic counselors, we spend quite a bit of time with people to kind of navigate those. The sense of guilt that can come with it, the heavy burden of letting their family members know that there is actually a real risk now, among other things. And the guidelines are changing, so I always tell my patients, if you tested negative now, let's check back in 5 years, there might be something new. We do see patients back quite often for update testing, and the guidelines shift too. So someone who may not have fit guidelines for testing a year ago or even a month ago would now, because of the new changes to pancreatic and prostate cancer. So it is always important to check in with a genetic specialist when you have the access, and see if there's anything new that can be added. And just our contact info.